Ladies and gentlemen, thank you for the privilege of participating in this session. This is not the University Hospital in Bergen. It is a lighthouse from a native district of the beautiful western coast of Norway. My name is Venny Kvalheim, and I work as a cardiac surgeon at the University in Bergen. I'm also a member of the circulatory research group at the university, and we have for several years worked with animal models on different aspects of fluid hemostasis during cardio-pulmonary bypass. I have mainly been involved in experimental studies aimed to reduce fluid overload during CPB by use of different hyperosmolar and colloidal solutions. In this session, I will share my thoughts about hyperosmolar solutions as additive to the prime. And my first thought was that the combination fluids are most interesting, so I took the liberty of making an additive to the name of the session. I will start with the reason why the choice of prime solution is important. Cumulative intraoperative fluid balances after CPB of several liters have not been uncommon. I believe the amount is relatively low during an ordinary, uncomplicated bypass today, although some overload is difficult to avoid. Surgical techniques, perfusion equipment, and monitoring devices have improved during the years, and sicker patients with more comorbidity have become acceptable candidates for cardiac surgery. Volume therapy is an important part of the treatment, and to optimize this might contribute toward better handling of high-risk patients undergoing cardiac surgery. The main reasons for fluid overload is hemodilution, inflammation, and hypothermia. Hemodilution was a progress in cardiac surgery, but a load of approximately 1,500 milliliter, sometimes more, sometimes less. Inflammation is also a contributor difficult to avoid, and increased capillary fluid leakage will demand more fluid. The degree of hypothermia and the length of this period will also contribute for even more leakage from the intravascular to the interstitial space. Although this guy is smiling, this is not the way we want our patients to look at intensive care. So the answer is quite obvious. It does matter. Several studies concerning this topic have proved that increasing fluid loading increases the possibilities for postoperative organ dysfunction. Melhan gives an overview how myocardial edema might lead to decreased ventricular compliance caused by among other things, increased myocardial stiffness. Bolt demonstrated how increased fluid load increased extravascular lung water and decreased lung function. A study from Toraman demonstrated that intraoperative volume overload is associated with a negative outcome, increased blood transfusion and increased length of stay in the hospital. Similar studies have also found for gastro patients. Changes have been done all the way to improve cardiopulmonary bypass. Hypothermia was needed to protect tissue, especially brain, by reducing oxygen needs. Today, deep hypothermia is rarely used in regular cardiac surgery, not only saving fluid because of the changes in temperature, but also time saved, cooling down and warming up. Improvements in CPB equipment have reduced prime volume. For instance, mini bypass, as we heard earlier. Controversies considering cardioplegia is not uncommon, but with a focus on saving fluid, blood cardioplegia is undoubtedly the best. What more can we do? Is it possible to improve the prime? The most common prime alternatives. Most centers use Ringer solutions with or without additives. Isotonic solutions like Ringer distribute rapidly throughout the entire extracellular space with no preference for the vascular space. It has been estimated that 3 units of Ringer is needed to replace 1 unit of blood. Most studies state this as an underestimation. Several different hyperosmolar solutions have been tested out, like mannitol and glucose, and increased osmolarity of all solutions produced rapid initial improvements. The response did not specifically require sodium or chloride. However, the decline in improvements was slowest with the hypertonic saline. Colloids are also commonly used additives. Hypertonic saline is most often tested as small volume resuscitation in bleeding after in animal models of circulatory shock, pre-hospitalized or in the emergency room. The first study from Velasco and co-workers reported that a small infusion of hypertonic saline rapidly restored arterial pressure and cardiac output to baseline values. It was 100% survival in the test group and a 0% survival in the control group. The results were so outstanding that the authors had difficulty publishing. Some years later, Nakayama and Kramer did an excellent study with bolus infusion of hypertonic saline in hemorrhage sheep. They demonstrated an improved cardiac performance, a reduction in total a fall in total peripheral resistance, and a reduction in and an increase in urine output. However, the improvements were short-lived. Everybody is of course familiar to the conception of hyperosmolarity, and the picture is just a quick reminder what happened once we give the patients hyperosmolar fluid. It is the fluid that is moving from the interstitium or intracellular space, where the reservoir are quite large, and into the intravascular space. The problem is to keep it there. Possible adverse effect of hypertonic saline, and I underline this is possible effects. To my knowledge, there is no study demonstrating obvious adverse effects when used in recommended dosages. Considerably elevated serum sodium have been reported, and neurological symptoms might be expected, but none have been described. An increased plasma chloride concentration could produce metabolic acidosis that might compromise cardiac function or cause arrhythmia. In a study from Vassar concerning potential risk associated with infusion of hypertonic saline in resuscitation situations, they found no correlation between pH and chloride concentration. This is in line with our findings in Vivarium. Austria was one of the first countries to approve hypertonic saline hyperoccultic solutions, and the patient material for adverse drug reaction is quite large. The main use has been as a small resuscitation volume in emergency situations. In a study of a 10-year material, it was concluded that hypertonic saline colloids carries a low potential for adverse drug reactions and can be considered safe. Colloids are an important additive to the CPB prime. Human albumin is an alternative with few adverse effects. It comes both as iso-oncotic and hyper-oncotic solution. It is derived from human plasma, but due to ethanol and heat treatment, viral transmission is very unlikely. It is considered to be the colloid with the least influence on coagulation. It can interfere with blood typing and may cause allergic reactions, though less frequent compared to other colloids. Albumin is also a transport molecule, which might be kept in mind if infusing large volumes to patients of multipharmacia. Compared to other colloids, it's very expensive. This is the prices from Norway, and I think they speak for themselves. In a retrospective study looking into almost 20,000 patients where cardiac surgery were performed, it was found that albumin might be worth the price. It was found that albumin appeared to be associated with lower incidence of mortality, but albumin was compared to all non-protein colloids, including dextran, galantines, and first generation of starch, and no separation of undergroups were done. A Cochrane meta-analysis in 1988 suggested worse outcome in patients given albumin in the intensive care unit. And in a SAFE study in 2004, which was a prospective study of 7,000 patients in intensive care unit, they didn't show any advantage of albumin as a plasma substitute. Whether it's worth the price or not is still a matter of debate. Hydroxyethyl starch is most often used colloid in Europe. It's derived from polysaccharides, corn and potato. and the first generation had a molecular weight of 4,600 kilodalton. There have been a continuous improvement of these solutions. Newest ones weighed only 130 kilodaltons. Effects and possible effects, adverse effects of starch are defined by molecular weight and by molar substitution. Large molecule, stronger effect, and the degree of molar substitution determines breakdown and elimination. Slow metabolization results in relatively long-lasting effect, but also risk of accumulation and higher risk of adverse effects. Starch might interfere with normal hemostasis at different levels, but this is mainly based on the first generation starch preparation with a high molecular weight and a high degree of molar substitution. Several studies using low weight molar substitution concludes with no enhanced bleeding or transfusion need. Some starch solutions have also been associated with kidney dysfunction, but also this has been related to high weight, high molar substitution. Bolt had a study with low weight, low molar substitution, where kidney function was not affected. And it was no negative effects in patients, and even with patients with altered kidney function, it was not altered. Anaphylactic reactions are rare for starch, estimated to be 0.006%, lower than for both dextran and galantin, a little bit more than for albumin, even though some studies estimate approximately the same for albumin and starch. Dextran is also a polysaccharide derivative. Due to impact of coagulation and anaphylactic reaction, the use of dextran is rarely in cardiac surgery today. Galantins are short-acting colloids and have been withdrawn from the market several places because of life-threatening anaphylactic reactions. It's difficult to talk about colloids and not mention the Starling equation. And now it's a terrible picture, but I just wanted to remind you that when the COP in the intracapillary fall, the net fluid flux, the fluid out of the capillaries will increase. This is just a picture illustrating the same thing. Hydrostatic pressure is pressuring the fluid out of the capillaries, while the COP is trying to keep it there. In our vivarium, we did a study on pigs where colloids were added to the prime to preserve COP. We observed a significantly improved fluid balance and reduced fluid extravasation rate. Total tissue water content of heart and lungs was reduced compared to the animals in the Ringer group. Several studies using colloids as a prime additive have been performed. Ising used a starch solution in a prime and compared it to a crystallite group. He found that starch preserved COP better and had significantly lower net fluid balance. The increase in cardiac index was more pronounced in the starch group, and extravascular lung water was increased by more than 20% in the crystallite group. No significant difference was observed according to bleeding. In a meta-analysis performed by Himpe, including almost 1,000 patients, it was concluded that colloid improves fluid balance, and albumin was not necessarily associated with better results than other colloids. Significantly higher platelet counts were found with crystallite compared to colloids, but no differences were found comparing bleeding. The rapid osmotic effect of the hypertonic saline mobilized fluid to the intravascular compartment. Maintaining COP with colloids contributes to keep the fluid there. The combination has a considerably better effect than each of them used alone. The combination of hypertonic saline and a colloid has been used before and after surgery with good results. Oliveira used a combination of hypertonic saline and dextran before cardiac surgery on a group of Jehovah's Witnesses. He observed a significantly better fluid balance. Hypertonic saline dextran group patients ran slightly negative balance, while a control group around a large positive balance. Although serum sodium values of 166 were obtained, no adverse effect were observed. Bolt also infused the hypertonic saline starch solution before cardiac surgery and obtained the same good results: an increased cardiac index, a decrease in systemic resistance, and an improved fluid balance. No negative impact on coagulation was observed. In another study from Bolt, he compared the hypertonic saline starch and only starch. He found that preoperative infusion of the combination fluid improved microcirculation before, during, and after CPB. Scott performed a study in children that underwent cardiac surgery, and he infused hypertonic saline starch immediately after surgery. The children in the hypertonic saline starch group obtained an increased cardiac index and a reduced extravascular lung water. No increased bleeding was observed, and it was concluded that an infusion of hypertonic saline starch is safe for children. Cerebral ischemia might occur during bypass and might be caused by air, by embolus, or by hypoperfusion related to the loss of atrial regulation. Increased intracranial pressure and cerebral edema may be worsened this ischemia. By reducing intracranial pressure and brain water, improved cerebral perfusion pressure may be obtained. McDaniel added hypertonic saline dextran in the prime in a pig study and observed a significantly better net fluid balance in this group. He also found a decreased intracranial pressure and a reduced cerebellar water content in animals. We did a study in our vivarium using hypertonic saline starch in the prime. We replaced 4 milliliter per kilo of the crystalloid prime with the hypertonic saline starch. No hyperthymia was performed and the bypass time was 2 hours. The animals drifted toward 35 degrees. The total fluid gain was reduced by 60%. Encouraged by our findings in vivarium, we did a clinical study on 49 patients scheduled for coronary artery bypass grafting. We used a slow perioperative infusion at 1 milliliter per kilo per hour of hypertonic saline starch for 4 hours and compared it to the same amount of Ringer solution. Hemodynamic parameters were obtained by pico catheter. We observed a reduced fluid load in the hyperhest group and improved cardiac performance. As you can see in this picture, the cardiac index increased in both groups, but significantly more in the hypertonic saline starch group 6 hours after surgery. Earlier studies where the solution had been given as a bolus during 15 to 20 minutes, the cardiac index increased with a peak value and thereafter had a decreasing trend throughout the postoperative hours. In our study, the cardiac index tended to increase in the 6 hours postoperatively, the period where the transient postoperative dysfunction might be expected. Given as a prime additive, we might expect the same effects as a slow perioperative infusion. According to the oxygen ratio, we found no significant differences, but looking at this curve, we can see an obvious trend where the hypertonic saline starch group tended to have a much more rapid recovery. For a summary, the hypertonic solutions might directly improve cardiac performance by increasing contractility. Effects are short-lived when used alone, most effective when combined with colloids. Colloidal additives reduces fluid load and counteract tissue edema. By use of low molar, low weight, low substitution degree in moderate volumes of HETA starch, adverse effect can be avoided. Combination fluids have been given before, under and after surgery with good results. Clinical studies using hypertonic saline as a prime have been difficult to find. From our animal research, we have good experience replacing some of the crystalloid prime with a hypertonic saline starch solution. Our focus in the fluid treatment during CPB should be to prohibit fluid load, not to replace losses. So my conclusion is that cardiac patients may benefit from the use of our hyperosmolar colloidal prime additive.
Thank you very much. We have time for a few short questions. Anyone from the floor?
From India, what is the proportion which you mix hypertonic saline and the starch? What is the proportion in the prime?
We gave 4 milliliter per kilo for 4 hours. In the prime, we just gave 4 milliliter per kilo of the animal.
That is saline, hypertonic saline.
Yes, and starch.
And how much starch? What is the ratio between two?
It's the product we use is heta starch.
Okay.
And it's 6% heta starch, and it comes as a finished solution. It is 6%.
And how much saline? 3% saline. How much? What is the quantity?
7.2%.
Saline.
Yes.
Okay.
I have a question. Do you have any recommendations about using diuretics during bypass, and because that can also influence the fluid balance?
Sorry, they lost.
That can also influence the fluid balance. The use of diuretics.
Yes.
Do you have any opinion about the use of diuretics during bypass?
No, we haven't done any study on that. But in a clinical study, we followed the diuretics use, and there was no difference in the groups. The groups, but that was the whole time before leaving the hospital, from bypass and intensive care unit, and the days afterwards, no more